We're going to talk briefly about a couple of other models, including hospital at home, which is a really interesting model that's trying to divert people 65 and older who are in need of inpatient admission from inpatient admission to receive their care at home, targeting some diagnoses that are really common reasons for ER visits and hospitalizations in older adults, including community-acquired pneumonia, heart failure, COPD, and cellulitis. And so if the patients are eligible, they're diverted to care at home, and they get nursing and physician care at home. That's their interprofessional team, a focused interprofessional team. They get all of their care, their equipment, their meds at home. All the testing is conducted at home. And when they're ready, they're discharged back to their primary care doc. And the outcomes are what you'd expect, again, positive. Decreased length of stay, high patient and caregiver satisfaction. No one wants to be in the hospital. They love being at home to get treatment. And decreased delirium. They're in their home environment in a setting they know. It's not confusing. And decreased cost of care. And a similar model, but home-based primary care, so bringing primary care to the home, very commonly used by the VA. Designed for frail older adults with multiple comorbidities. And so primary care is given directly in the patient's home. It involves care coordination, home visits, telephone calls, with a broad interprofessional team that's usually funded by the VA. Geriatricians, NPs, social workers, LPNs, and office coordinators. And the outcomes, again, include high patient satisfaction. And there's the interprofessional model for practice, model of practice for aging and complex treatments, the IMPACT model. So here, the interprofessional team is again a broad team, including primary care, nursing, pharmacy, PT/OT, dietitians, and social workers, and it also incorporates, importantly, trainees from each profession. So this is more similar to our model of care in the Center of Excellence for Alzheimer's Disease at SUNY Downstate, in which we incorporate a broad panel of healthcare professionals and also trainees from each profession into patient care. And the outcomes here are great. And so this is what that model looks like. Interprofessional care and education are wrapped around all of the professionals working together to provide care to the patient and family across a very intensive IMPACT clinic protocol that involves patient selection, comprehensive assessment, team meetings, team planning, person-centered care planning, and iterative care review and implementation to improve and optimize care outcomes. So let's turn back to our patient and talk about her interval history. So earlier we reviewed her past history, and now she's in your office and we're getting an update by problem. In regard to her falls, since last appointment, the patient has had 2 new ER visits for falls. This makes her very high risk for falls if she wasn't already. Both happened at night, no head injuries, but now she has a right wrist fracture. In regard to her hypertension, the patient was not able to keep a log of BP, but she does now have current hypertension, 157/94. So we're looking at her and we're thinking, where are the holes in her care? Where can we intervene as an interprofessional team to improve her outcome and prevent falls and optimize either her medication adherence or medication plan? Thinking again about the 4 M's, right? Here we're seeing some problems in mobility and perhaps medications as well. In regard to her heart failure, she's now sleeping on 2 pillows. She's only able to walk 1 block without resting or 1 flight of stairs. And there should be an alarm bell going off in your head right now as you think about her living environment. Mrs. Cologne lives on the 4th floor of a 4-story walk-up building in Brooklyn. And so it must be taking her a whole lot of time to move up and down those stairs, one. And also, if she is getting dizzy and out of breath at each flight, is she at further fall risk on the stairs and at risk for severe injury? Mobility, right? One of the 4 M's. Her diabetes. Patient was not able to keep a log. Finger stick, 189 today. Hemoglobin A1C, 8.9. She's not controlled and has not modified her diet. But thinking again about what's going on with her, put on your thinking hat. She has a broken right wrist. Is she able to cook? Probably not. Is she ordering in? Probably. And it's hard to get inexpensive, healthy delivery food, even in New York City. Hyperlipidemia, again, she hasn't modified her diet. Osteoporosis. She's taking Tylenol multiple times a day. And 4 M's, we're thinking about medication here and how that Tylenol is impacting her liver and how it's impacting, perhaps interacting with other meds, and how it's also interacting with her alcohol consumption. We don't know where she is right now with that alcohol use. Mentation-wise, her mini mental is 26 out of 30 today. That's still within the normal range, but perhaps off her baseline. She doesn't have any functional deficits from her cognitive impairment, so she doesn't qualify as having a diagnosis of dementia. And then on to her alcohol. So she's still drinking 3 large glasses of wine, and so now we're wise to what's happening, and we're asking a few more questions. What does 2 to 3 glasses mean? And it wasn't the standard 4 to 5 ounce glass of wine. It was a full 12 ounce glass, perhaps 8 to 12 ounce glass that she was drinking 3 of per day. And so actually the actual number of drinks that she was getting was somewhere in the neighborhood of 6 to 10. But she didn't see this as a problem, saying, I'm retired, I'm independent, I'll do what I want with my time. Very resistant to any insinuation that this was too much for her. Social history-wise, interval history, she stopped attending church. She had due to the difficulty with the stairs. Her children aren't visiting due to their work schedules. They call her, but they're not visiting. And she doesn't have a home health aide. So now we have a woman, fiercely independent, who's had 2 new falls, right wrist fracture, having difficulty cooking for herself, difficulty ambulating up and down stairs, and relatively isolated from all of her social network. We need everyone on board, right? The whole interprofessional team. Geriatricians, nursing, PT, OT, social work, pharmacy. And she's been losing weight. Preventive care-wise, she hasn't engaged in any of the preventive care that you'd referred her for based on her comorbidities. No optho, no podiatry, no dentistry. So we need these guys involved in her care too. And on asking what matters most to our patient, she said, I want to stay in my home. This is where my whole family was raised, and my husband passed. And so now we have to be thinking as an interprofessional team about this patient and how we can take in all of her complexity and help her to meet her goal of aging in her home. This is a tricky one, but it's important. And just a reminder about her medications in case you'd forgotten. So I'd like to have a stop for a second to remind you to confront ageism when it happens. It's very common with a case like this for us to push for the patient to perhaps have placement into an assisted living or other skilled nursing facility perhaps. But we have to take into account the patient's goal for herself, what is most important to her and what's going to help her maintain her happiness, her mentation, which includes her mood and affect, and her long-term life goals. And that, at this point, does not include placement into a facility, certainly. And so we have to check ourselves and make sure that our care is in line with our patient's desires and find the best middle ground in which everyone is satisfied with both patient safety, patient care, and person-centered outcome. So as we've been doing all along, I'd like you to pause for a minute and consider this patient in the context of the 4 M's. Take a moment to write down how you think we're doing with her care across each of those 4 M's: medication, mentation, mobility, and what matters. What should we do as a team to optimize her care and ensure that we adhere to what matters? And again, think again about what model of care might serve this patient best. Think about those models that we went through.